Welcome everybody to this second webinar in the series by the International Society for Quality in Healthcare and the Clinical Excellence Commission. This morning we have people joining us from a range of different regions, and many of you will have joined us for the previous webinar, which was on HSNRs. That webinar has been recorded and is now available on the ISQua website. So if you didn't happen to get to that webinar, please make sure you check that one out as well. Today we have over 40 people registered from a range of different areas: Chief Executive Officers, Directors of Clinical Governance Unit staff, Patient Safety Managers and Officers, consumer feedback managers, and people working in the community. So we're very excited that you'll be joining with us today. I just want to let you know that this webinar will be recorded and it will be available on the ISQua website at a later date. My name's Dr. Karen Luxford. I'm the Director of Patient-Based Care at the Clinical Excellence Commission, and I'll be facilitating today's webinar. There is a chat facility available. You'll see the chat as a small box on the screen of your computer. If you want to send in questions to the speaker during the webinar, please just type them directly into that chat box, and at the end of the talk, we'll relay those questions through to the speaker. I'm pleased to welcome today Dr. Susan Patton, who's going to be our speaker. I also wanted to tell you just a little bit about ISQua, the International Society for Quality in Healthcare, which many of you will be familiar with. Also is running a fellowship program at the moment. So if you register for that program, you'll be eligible for points for participating in activities like today's webinar. And the other partner in today's webinar on the next slide is the Clinical Excellence Commission. We work in safety and quality. We're a New South Wales-based group here in Australia, and we have many resources on our website as well, so please check us out. I'm very, very excited about being able to introduce today Dr. Susan Patton, who is the President of Planetree International, which is based in the US. Susan is internationally recognised as a leader in patient-focused care, and she's going to be sharing some of her knowledge and experience with us today, and you'll be able to send through questions. So please do that while Susan is speaking. I'll hand over to you, Susan.
Okay, thank you very much, Karen. It's really a pleasure to have an opportunity to talk with folks about patient partnerships, improving healthcare quality. And when I thought about this topic, it struck me that it might be most fitting to begin the conversation by talking with patients about their perspectives on partnership and the impact on quality. And so I contacted a couple of colleagues in the field of patient-centered care, patient advocates, and asked them for their impressions. And I'd like to begin by sharing some of their thoughts on partnerships. And this is a quote that one of my colleagues sent me. She said, this is a saying in Africa: when the center is weak, things fall apart. And her perception was that today still patients have a weak position in many healthcare systems, and that things have been falling apart because the patient hasn't been the center of care. When patients trust their care providers and know that they're loved, the care provider becomes family. However, care providers haven't been trained to listen to patient opinions. I thought this was a very telling quote, and the person who shared this with me is Longara, and Alice is a patient rights advocate and the founder of an organization called the Morris Moses Foundation, which is based in Kenya. And Alice is a staunch pioneer in sub-Saharan Africa, working for patients' rights in her area and within her sphere of influence. And she was unfortunately had to deal a number of years ago with the death of both her father and brother due to medical negligence in a hospital in Kenya. And she's turned that experience into a crusade to ensure that indeed patients are treated more equitably and have more rights in Kenya in order to improve the quality of healthcare. She was recently instrumental in launching the Kenya National Patients' Rights Charter, which is the first patient rights charter in the country. So she's really spearheading a movement, and it's resulted in some wonderful activity around partnership and improving quality. And I thought it was a wonderful opportunity to shine a light on some of the work that she's doing in the developing world around patient partnership. The next quote I wanted to share was actually from a press release. When I thought about Alice's perspectives on patient partnership and some of the critical needs, it included that line about practitioners not being trained to listen to patients. And I think many of us realize that in the training, and particularly the training of physicians, there's not a great deal of focus placed on communication skills, interpersonal relationships with patients and family, and that's been, I think, detrimental to the practice of true patient-centered care. And so when I saw this press release that came out just a week or two ago, I was very excited, as well as the reporter who reported on this. And this is a press release about a brand new medical school that is opening in Connecticut in the U.S. And it's a unique program in that physicians will be trained side by side with nurses. They will be in the same classes together, and the medical students will come out with a medical degree, and the nursing students will come out with doctoral degrees in nursing. And so certainly there will be more of a focus on team-based care, which is something that's important to improving quality in the way that we deliver care. But also they'll be using Plaintree patient-centered hospitals as opportunities to expose the students early on to what patient-centered care looks like in a clinical setting. And so I was very pleased when the dean of this new medical school, Bruce Copen, did decide to move forward and use patient-centered hospital as a training site as a part of this program. I hope to see more and more of this replicated around the world. So the next quote I want to share is be mutually respectful of each other's contributions. Your doctor is an expert in medicine, but you are an expert in you, and patients are the most underutilized resource in healthcare. And I think many of us would agree that we've marginalized patients in many ways and haven't extended true partnership to them, and that's something that needs to change and is beginning to change. And there are social media experts out there agitating for this change, and this quote is from ePatient Dave, who many of us are becoming quite familiar with, Dave DeBrockart. He speaks internationally about the importance of sharing information with patients and families, engaging them as partners in their medical care. And he shares his story, which is very inspirational, about his own personal challenge when he was diagnosed with terminal cancer. Obviously, it wasn't too terminal because a couple years later he's still with us, but he felt that his ability to go out on the internet, to tap into the experiences of fellow patients who had the same or similar challenges, look for his own information about treatment options, saved his life. And he's really become a crusader for open access to information and to the power of patients networking directly with other patients, in addition to partnering with their healthcare team. And so I think that was a wonderful example of what's changing in terms of access to information. And then the third patient advocate I wanted to quote today is Regina Holiday. And if you're not familiar with Regina, I would encourage you to go onto YouTube. There are quite a few inspirational videos on YouTube that Regina has filmed, and one in particular is about access to the medical record. And she is a very passionate supporter of that. She shares her personal story when her husband was diagnosed with cancer and the challenges that she had as his care partner trying to access his medical record, and how many obstacles were really put in her way by the healthcare system the way it's currently organized. She was finally able to access the information that she needed, but very late in her husband's treatment experience. And so she has become another social media agitator out there, helping to promote this cause of open access to information, particularly medical record information. And she's created something that I think has captured people's attention because of both the personal nature of this, but also the power of personal stories. And Regina has created something called the Walking Gallery. And these paintings that you see on the screen are some of the paintings that she recently did for the annual Plaintree Conference. And she had invited us to send stories, our own personal stories, our family stories, stories of patients that we knew. And she then painted her interpretation of those stories on the backs of each of our jackets. And this is called the Walking Gallery. And she's now done this for hundreds of people, portraying their patient stories. And then she asked that people wear those jackets and tell their story. So it's a wonderful way of blending art with advocacy to get patient stories, the power of those personal stories out there to help change our system and to encourage that partnership that we're talking about today. I also asked a couple of colleagues that aren't patient advocates themselves, but certainly advocates are very strong advocates and supporters for patient rights. And this individual said, well, if I was thinking about patient partnership, I'd say that it really needs to begin in the home. And we need to make sure that we have adequate support built into our system to allow and encourage people to remain at home as long as they possibly can. And this is certainly an important opportunity in terms of partnership because, as we know, our systems, many of our systems are not adequately set up to provide all the supports necessary to a frail elderly person who may have multiple chronic conditions they're dealing with, who would prefer to stay at home versus being in a nursing facility. This is Régine Hébert, the Minister of Health in Quebec, and this is a focus in the province of Quebec to make sure that supports are in place to do this. I also found it interesting recently in talking with colleagues in the Netherlands that there's a stated goal now in the Netherlands to move as many individuals out of skilled nursing facilities as possible and back into home settings. And they are organizing supports, community support systems to make sure that those individuals are safe and well cared for, but able to remain in a domestic setting. And then the last quote that I'll share before we open it up for questions and discussion is one about the importance of partnering with patients on outcomes measurement. And if there's one thing that we have a huge opportunity to do, it's to do a better job of including patients in our research activities and our measurement activities, and to begin to change the way that we view what a good outcome is to incorporate the patient's reported outcome. And so this quote, the greatest challenge that we face is unexplained clinical variation in the work we do every day. We have an obligation to evaluate and measure all of our work to figure out what works and what doesn't, and will then reduce waste, reduce harm, and achieve value for the care we deliver. The patient's reported outcome is essential. And so we are seeing a movement in many countries towards patient-reported outcome measures. And I want to give just a brief personal example of this. And first I'll put up the individual who sent this quote in, is David Nash, who's the Dean of the Jefferson School of Population Health in Philadelphia. So patient-reported outcomes, what do we mean when we talk about that? So imagine you've just had a knee replacement and you had a conversation with your physician about should I, shouldn't I, but there was no conversation about, well, why exactly do you want the knee replacement? What are you hoping for as an outcome? How would you, as the patient, define a good outcome? And I had that conversation with a friend recently who had a knee replacement, and she said, the one thing I really wanted to be able to do again was go out and walk in the woods. I love doing that, but I haven't been able to do that for years because of my deteriorating knee. And so I was talking with her 2 years after her knee replacement, and she said, you know, it was such a waste of time. My knee is just as painful as it was before the knee replacement. I can't get out and walk in the woods, and I really feel like someone should have told me that this was a potential outcome, and that was not shared with me. And I said, well, did you ever have that conversation with your physician about what your how you would define a successful outcome? And she said, no. She said, it's been frustrating when I talked to my surgeon. He says, this was a successful knee replacement. There was no postoperative infection. Everything is healed up. So from the surgeon's perspective, it was a successful outcome. From the patient's perspective, it absolutely was not. And so we need to be moving to a place where we understand that the patient's values are just as important as the way we're historically defining a good clinical outcome. So we have lots of opportunity and work to do in that area as well. So we have just a little over 10 minutes for questions and discussion, and so I want to open that up to our participants.
Thank you very much, Susan. I wanted to just ask you briefly about your last comment about values and expectations. I think it's a very much a cultural shift. It's a paradigm shift to get people to be thinking, you know, how can I convey my expectations to the clinician that I'm working in partnership with? Do you have any comments about that? I'm aware of some of the literature that suggests that clinicians' estimations of what those expectations will be do not match up with what patient expectations actually are. So
yeah,
I'd love to hear your comments.
Yeah, Karen, that's a great point, and you're right. The research literature essentially shows that clinicians often believe that the outcome or success or what someone might prefer is very, very different from what individual patients would actually express. And I think it points out the essential importance of having these conversations with the patient beforehand. And I think that this is also at the heart of the movement that we see towards shared decision-making, recognizing that the patient's preferences and the patient's values and their tolerance for risk and how they would define a successful outcome is absolutely essential information to have going into any treatment plan, particularly if it's a preference-sensitive diagnosis where there's not one clear path that everyone would agree is the only way to go. Because in many cases, that's just not true, that there may be a number of different options, and patients need to know what those options are. They need to have the ability to have that conversation with the clinician to try to weigh what will truly be best for them. And I think this will move us toward true informed decision-making, because I don't know that we really have that in place at this time.
We've received a question from Anne Axum just asking us about patients and consumers as drivers. It's very powerful, but how much more powerful would it be if we had the clinicians really driving this engagement?
Yeah, I think it's a wonderful thing, and it's kind of the ideal to have both consumers and clinicians on the same track here. And I have to say, I believe that patient-centered care is gaining traction amongst clinicians, and I've seen an increase in interest in leadership around this on the part of physicians and nurses who are beginning to understand the importance of truly partnering with patients and how much more fulfilling it is for them. I remember just a few years ago speaking with a physician colleague who said, I do a lot of speaking to physician groups, and I often ask physicians, how many of you would go into medicine again if you were at the start of your career? And very few hands go up in the audience. So there's a bit of a disconnect even for physicians in terms of what they thought the practice of medicine was going to be like, and that idealism that many of us have early in our healthcare careers, to work with patients, to serve other people. And the system, I think, often sort of drags clinicians down, and it's not as fulfilling as they thought it would be. And I think many of them are able to re-experience what they thought medicine or nursing might be when they do engage in some of these kinds of partnering practices. So it's kind of self-reinforcing.
Thank you. Susan, we've had another question, this time from Linda Johnson, just asking if you've got any hot tips for success about a situation where initially the hospital that you're working with has what you might consider a poor culture, and that you want to actually get things really moving, shared decision making, patient-based care. What are your thoughts about the groundwork?
Yeah, I think it's absolutely essential to do a culture assessment in an organization. We often call it an organizational assessment, but you're really assessing the organization's culture. And to do that based on conversation with patients that have received care there recently, with their family members to evaluate their experience, and with direct caregivers that provide service in that organization. And to have that conversation, we often do this in the form of focus groups, but having that conversation about what is the lived experience like to receive care in this setting and to deliver care in this setting, and where are the priorities for change that patients, families, and caregivers would identify. And then to use those identified priorities as the strategy to begin to move in a different direction. One of the things that we found is when we collect patient quotes about their care experience and share that with their caregivers, it's often this wake-up call that people don't realize what the patient has experienced or how that has felt to them. And that by sharing that, it's often a way of galvanizing people to change. And then I think one of the other important laying of groundwork pieces here is exposing caregivers in some very interactive ways to the patient's experience. And we've alternately called this patient experience training or patient immersion training or staff sensitivity training. But it's really helping staff to walk in the shoes of the patient and the family so that they get a better understanding of what does it feel like to come into a clinical setting where much of your power as an autonomous individual is taken away just because of the way we've organized our healthcare delivery system. And to experience that for yourself, to sort of change that mindset and to begin to think about what could I do differently in the way that I deliver care to help patients and families feel more comfortable, to make them feel like they are partners, that they have some control, some decision-making abilities. So I think starting with a cultural assessment and then staff education and training are two of the hot tips that I would suggest.
That we're just wondering about is strategies for quality departments and quality managers in hospitals to help to develop a new culture where the patient will assume that new role in improving the safety and quality of their own care. And this is a big step, and we've had lots of discussions locally about engaging patients in hand hygiene activities, in notifying early warning systems for medical errors. Do you have thoughts about how that can be integrated into a hospital system?
Yeah, absolutely. I think it's really important that quality managers work very closely with the clinical care team, and particularly nursing, to identify opportunities to engage patients and their family members in quality improvement activities. And one example I can think of that was very successful was at a hospital, large hospital that we were working with in San Diego, and they had an unacceptable fall rate in their hospital, and they decided, because the quality department was monitoring this, that they needed a fall reduction program. And so quality teamed up with nursing and involved patients and families from the Patient Family Advisory Council to say, here's the problem, here's our challenge, what sort of strategies can we work together on to reduce falls in our hospital? And that combination of team members working on it came up with a very effective fall risk reduction program that included not just activities that the staff was responsible for, which is how we often engage in quality improvement or risk reduction programs, but also what the patients and their family members do to help reduce fall risk. And so the program actually began to incorporate a patient and family risk profile, which they filled out when they came into the clinical setting. So they talked about where they thought there might be fall risks and ways that they could be supported or the loved one could be supported when they're in the clinical setting to reduce falls. And that then went into the chart, and that was something that was accessed then by staff. And so the nursing staff had a sense of where are the vulnerabilities as identified by the patient and the family. That's such important information that generally we never ask. And again, I love to use real stories to illustrate this. You know, my mom was hospitalized a few years ago, and if I had been asked about what her fall risk was, I would have said her greatest fall risk is the fact that you have her in an open back gown, because every time she gets out of bed to use the toilet, she's not paying attention to the IV pole and all of these wires and things. She's grabbing for the back of the gown to pull those pieces together so that her rear end is not hanging out. So I could have told people that, but staff wouldn't know that unless they engaged me or my mom as partners in care. So there's such power in something as simple as asking patients and family for their thoughts about risk reduction and quality improvement strategies.
Absolutely. Thank you for that, Susan. I wondered just in closing if you would be able to share with us what you think the biggest challenges are, particularly from your experience in the US and other countries, going forward in this area of partnering with patients.
I think that there are two things. I think one is that often we think we're already doing it. We think we're already patient-centered, and we've got it under control, and we're comfortable in the way we do things, and that's a barrier to change. I think the other is being open to sharing power with patients and families. And in the past, that's just not something that we've done. We've really created cultures in healthcare that are very disempowering to patients and keep them as more passive recipients of care instead of partners in their care. So that's a huge philosophical shift for us in healthcare. And I don't think we should underestimate that. But I think a lot of the activities that we're seeing now are going to help us to move in the right direction.
Fantastic. Thank you very much for sharing your insights with us this morning, Susan. And I'd just like to remind people that there is a future webinar coming up on the 1st of November, which will be Dr. John Wakefield and Associate Professor Tim Shaw will be looking at strategies for how to bring about change, particularly with a clinical audience. So I'm hoping you'll join us for that as well. So thank you for your time today. We thank you, Susan. And just to remind you that today will be recorded and available through the ISQua website. Thank you. Goodbye.